Hi ladies, thank you for coming today. As you know, we're trying to attain magnet status here at the hospital, and so there are, certain best practices that we're trying to follow to reduce length of stay and have improved patient outcomes. The thing that I wanted to talk to you about today is ventilator-acquired pneumonia. So, as you all know from taking Tina Brashear's pathophysiology class, anything invasive in a patient puts them at risk for infection. So we have a VAP bundle here.
So what's included in the VAP bundle?
I'm glad that you asked, Heather. I actually have a star so that we can remember all of the points. So the first thing is keeping the head of the bed elevated to 30 degrees or greater than, as long as their condition doesn't prohibit that, like they have a cervical spine injury and we're not allowed to raise their head of the bed. Oral care every 4 hours, and we document that in EPIC. DVT prophylaxis as ordered by the physician, that's your heparin, your Lovenox. Peptic ulcer prophylaxis, you all normally use Pepcid up here. And then we have the daily sedation interruption and spontaneous breathing trial.
What's that?
So for instance, when our patients are on drips like your propofol, dexmedetomidine, your sedatives, not your analgesics like fentanyl or things that we use for pain, Dilaudid, but things that are sedating the patient to keep them calm, or for tube tolerance, we stop every day, and we stop at 9 o'clock. It'll come up in your MAR in EPIC, and you will chart that you have stopped your sedation, and that's when the physicians are rounding, so that we're able to do, our whole group is able to do a neuro check. And the respiratory therapist also rounds at that time with us and does their spontaneous breathing trial to see if they're ready for extubation. If they're not ready to be extubated, as evidenced by their spontaneous breathing trial, or they're exhibiting behaviors that may put them at risk for self-injury, for instance, we will go ahead and deliver 2 PRN boluses of the medication that they're on, as ordered by the physician, and then restart their drip at half the rate.
Great, thank you.
And just so you know, I do chart audits weekly, and this is something that you will get. I post these in the lounge, and I also put this out as an email to let you know how we're doing with our documentation. This is an example of where I've audited for documentation of oral care every 4 hours, and the head of the bed being elevated to 30 degrees. Next month I'm going to be looking more at the spontaneous breathing trial, so that's in the sedation interruption. That's why we're going over this today, so that we can show that we're in compliance with that.
All right, Heather, if you want to follow me for a bedside report. We always do reporting at the bedside here at UVA, okay? Now, here we have Mrs. Bieber. She's a 49-year-old patient of Dr. Armstrong's. She's a full code, allergic to aspirin. She has been admitted for a pontine hemorrhage. Now, going through the systems, neurologically, she's a 1-1T. Obviously, she's intubated. We haven't made any attempts at ventilating yet. Her CV, she has a central line. She's on propofol at 40 mics per kilo per minute, and she's on normal saline that's running at 125 cc's an hour. As far as her family, her care partners are her husband and her daughter. Her husband has been here and gone for the day. Her daughter, I haven't seen her around. And I think that's it. Do you have any questions for me?
Yeah, you haven't mentioned the daily sedation interruption yet.
Yeah, that's probably because she's way too sick of a patient to have sedation interruption. I mean, I told you, we haven't even started ventilating yet. There's no way that she's ready for that. I mean, I don't know where you've come from. Probably a small community hospital like Culpeper, where the patients aren't nearly as sick. But this is UVA, a high-risk acute care hospital, and that's just not something we do. Okay?
Okay.
Let's go. And hopefully, while you're here at a high-risk hospital like UVA, Acute Care Medical Center, you'll learn some things about patients like this.
Okay, I mean, you've been here a long time, so, and I'm kind of new here, but I'll continue using the VAT bundle standards, but your decisions are your decisions, so.
All right. All right, Heather, I'll have to admit that you're right about bringing up the sedation interruption because some patients, even if they're sick, they still need it, okay? That's why we have a respiratory therapist here. She's doing a spontaneous breathing trial so we can see, as we take her off the sedation, how she handles the being intubated, okay? So
Okay.
first you're gonna assess her and say, Mrs. Bieber, see how her eyes are rolling back? See, that's a good sign. Mrs. Bieber, can we get a thumbs up? Can we get a thumbs up? Okay, good.
Good.
See, gradually as she comes off the sedation, she'll start to become a little bit more agitated.
Yeah, her legs are moving a bit, her arms.
Her arms, yeah. Seems like she doesn't like.
Is this normal?
She doesn't like. Oh. Okay, Mrs. Bieber. All right, quit the propofol
Okay.
and give it to her so that she can become calm again.
Here's the propofol. All right, it's in.
Perfect.
Hey Lee, can I ask you a quick question? Absolutely, come on in. So earlier today I was with my patient in Rihanna and I noticed that she didn't quite adhere to the VAT bundle, specifically the sedation interruption. So I'm wondering if that's something you guys use here at UVA, because at my old community hospital we adhere to the VAT bundle pretty strictly.
Yeah, so here at UVA, our two primary goals are to reduce readmissions and reduce the length of stay. So adherence to all components of the VAT bundle is very important in helping us to achieve these goals. So I'll definitely bring that up at the next staff meeting, and thanks so much for bringing that to my attention.
Great.
I'm gonna throw a little ringer in for you guys too, that you're not gonna be able to
Oh.
stop from laughing.
Oh no.
No.
The full code.
Can I add
allergic to
something?
aspirin.
Can I add a prop?
Yeah, sure. Oh, I need an RN. Okay.
One for each of you.
Nice upgrade. She's a 49-year-old patient of Dr. Armstrong's. She's a full code.
You gotta get way closer.
Really?
Yeah, you're not in it. Devin's not in it at all.
Wait, that was funny. All right, Heather. Now we'll do our next patient report bedside. That's what we do here at UVA. We do our bedside reporting at the bedside. So.
You said bedside like that.
Okay, Mrs. Bieber. All right, quick. Grab the bolus. Grab the bolus of propofol. Oh no!
It's injected.
That's a bad
It's become extubated. That's horrible. This is all your fault, Heather.
I should just quit my job as a nurse.
That part.
Sorry.
What if you're a millionaire getting paid by like Bruce Willis too?
Oh my God. Bruce Willis. Team planners manager. Okay. Lee, can I ask you a question?
Absolutely, come on in.
So I was with my patient in Brianna earlier, and I noticed that she didn't use the VAT bundle, which is something that I used at my old hospital, and I was just wondering if it's something that you do. I'm trying not to look at you.
Why?
Because we'll laugh.